בוקר טוב, תודה רבה שהזמנתם אותי. אני מאוד שמח להיות פה בחיפה ובישראל. לצערי, אני אתן את רוב ההרצאה באנגלית. אלא יכול להיות שיהיו הזדמנויות להשתפר בעברית שלי. לא. You have to try. אף אחד לא עדיין הרים את ידך, הרים את ידו. מישהו רוצה? מישהו רוצה לקרוא את זה בשבילנו?
יש חולים רבים עם בעיית מימוש הפוטנציאל העצמי שלהם, הם צריכים כדי להישאר גבוהים.
טוב, כאן. חולה? אנא?
אנא, הרם את היד שלך אם אתה רוצה לעשות משהו בקשר לזה.
אוקיי, אז אף אחד לא מרים את היד? מישהו רוצה להרים את היד? לא? בבקשה. Okay, if you can't even raise your hand for that, okay. Okay. So at least some of the English speakers know how to raise their hands. So thank you very much for having me. I'm very happy to be here on many levels. First to say, I've been working a lot in this field of health literacy, and the field really has to expand for a lot of reasons. First of all, it really needs to, this is a field that desperately needs to be engaged in a transdisciplinary perspective. And anytime we can expand the circle of the types of voices that participate in research in this field, the better. Also, as you've already heard, it's really very important in this field and many others to learn about best practices around the world. This really needs to be an international effort. Already this morning I met people from Uganda, from Nepal, from Swaziland. It has to be an international effort. And also people from Israel, right? There are interesting things that connect the Israeli system and the American system. There are issues that are actually much better here, and there are issues that are much worse here. And this, the same in comparison to the United States. Much of the data that I'm going to show you is from the United States. But really, part of the idea of today is to help bring you into the idea that Israel has to do this work too, and you're going to hear information later from people even sitting in the front row talking to each other, about some of the initial... about some of the initial work being done in Israel, in this arena. I have to say, there's another reason why I'm very, very happy to be in Haifa right now, which is that I was able to visit a relative of mine who died 2 days ago, you can see. So Tzvi Davis, I got to visit him here in Haifa. He lived most of his life here. He was born in Berlin, and he was on the kinder transport, and at a young age, to escape the bad place where he was sent, he lied about his age and he went into the British Army. He became a paratrooper in the British Army, and he jumped in Normandy. He jumped at Omaha Beach, if people know about Normandy. Later on, he was later on dropped again into the Rhineland and fought all of his way back to his own house in Berlin. Later on, he was stationed in Alexandria, and he found that one relative of his survived and lived in Kibbutz Suba. One relative of his whole family survived. So he came as a British soldier to Palestine in 1945, as a British soldier, and then he was restationed as a British soldier in Palestine and was a spy for the Haganah. Later on, he went back to England, and then in 1948, he came as a machalnik. He came as a midnadev chul, and he was stationed in Achuza. In Machal, he was stationed in Achuza, and he died 2 days ago. So I want to dedicate to him. So what's my goal? My goal for today is to talk to you about what is health literacy. In general, you have to start with some definitions, because people use this term, but what does it even mean? And there can be some debate about the term and what is the definition. After that, I want to talk to you about the prevalence of this issue in the United States, and you're going to hear more about the prevalence of this issue in Israel later on today. Then I want to explain at least my perspective and my kind of distillation of the data in this field for how it is that a person with limited literacy ends up with worse health outcomes. And I'm going to try to describe some things that health systems can do, that public health can do, and then show you some examples from my own research. Okay. So literacy is inherently a functional concept. You know, you can talk about different kinds of literacy. You can say, you know, there's literacies in different areas. Computer literacy, there's how to fix a car. Your mechanic actually has a special area of information that maybe you don't have. Certainly I don't have. My wife tells me there's a concept of even literacy with, you know, fashion literacy, whatever. I just listen to her and that's okay. But as it is, you have to think about this as a special area of skills relating to a specific domain of things that you need to do. And there's a lot of issues about this that are good to clarify. First of all, there are some basic skills that if you don't have them, it's actually quite challenging to learn new stuff. Things that basic literacy skills like reading and writing and how to use numbers, they're very, very useful, but in the end, it's all contextual. It's all contextual. There's no one literacy. By the way, that also means there's no one illiteracy. You might say this person can't read, but they can fix your car better than you. Or they can actually run the whole orchard and you have no idea how to do that. So there's no one literacy. In a healthcare context, though, it's a very specific type of arena of skills. And it really depends on what your tasks are. So the skills you need to take care of yourself for diabetes is different. And you may only come to that later in your life, and you need to be able to do those things and be able to take care of yourself with, say, with diabetes or with asthma, things you didn't need to know earlier, need to know how to do. And also the demands are completely contextual. So, you know, it is affected by the environment that you're in, by the way the clinicians, the way the doctors are talking, by the way the public health sector is communicating. It's all contextual, and we'll talk more about that later. This is the main definition in the United States. Someone can read it for me? Who's going to be my first volunteer? I need a volunteer. There you go.
The degree-rich individuals have the capacity to obtain, process, and understand basic health information and services needed to take appropriate health decisions.
Okay, this is the official U.S. definition. It's in Healthy People 2010. It's also Healthy People 2020. I should fix the slide. It's one of the main definitions out there. And there's some problems from my perspective with this definition. First of all, what's basic to one person is critical to another person. There's really kind of, it's very hard to say what is basic. You know, what to you is like basic to another person is not even relevant. You know, if you have cancer and someone's asking you, do you want to take this chemotherapy or this radiation therapy or this surgery, that information is now all of a sudden basic for you. You have to know how to deal with that. So the word basic really should not be in the definition at all. The next, it's not just information and services, but it's also skills. There's very important to have a focus on skills. There's a lot, in general, literacy has to have the concept of skills involved. The next problem with this definition is this word, appropriate. Appropriateness has nothing to do with the concept of literacy. What's appropriate is your perspective, another person's perspective. You know, when the doctor says, I want you to take this medicine, if you don't do it, there's a lot of possible reasons. You might just disagree. You might say, you know, I don't want to do that, you know. So it's not about appropriateness, it's about how informed you are. If you're an informed consumer of healthcare, if you're an informed member of the public health, you know, in terms of being a public health consumer of information, you need to be informed. So appropriateness is really not relevant exactly. The next problem with this, and the last one before I can go on, is the definition focuses on individuals. And I told you, literacy has to be conceptualized as a contextual phenomenon. That means, and I hope that I have support in this room from a public health perspective, that we really should stand back and say, well, really it should not focus too much on individuals. It has to focus on the system, on the whole system. You know, if we introduce unnecessary complexity and then focus on the individual, then we're just blaming the victim of our incompetence. I'll give you some examples that show, some of the issues, maybe just because we have a nice representation from the insurance sector with, how do you enroll in a health plan? How do you know what your health benefits are? How do you know what to do, how to access your services appropriately? That's kind of like, not just what are your services, the knowledge of it, but actually how do you go about getting this information? How do you understand how to use your glucometer? Do you use your inhaler correctly? Most people do not use their inhaler correctly. If you go and test people for their inhaler, they're not doing it correctly. All right. Now, in general, the health context is also very, very complicated, much too complicated. I was talking to some people from developing countries earlier, and I would say maybe they have a challenge that's slightly different. More money has to be invested in their health sectors, but you have an opportunity to get in on the ground floor and make sure that from the beginning, your health sector is developed in a way that people can use it and that it's understandable. In a place like Israel or in the United States, a lot has been developed in the health sector, but we've created health systems that are more complicated than people can consume, can use. And so there's too much information, and there's not enough time. Often we go at people with information when they're not really at their best. So it's very hard for them to understand what we're talking about. If I tell you, I want to tell you about cancer, many people cannot process any more information after that because they're just focused, oh my gosh, you just said cancer, you think I have cancer? And it's like, you can't process more information after. You have to actually think about the person as a learner and how is it going to work in their life to actually process the information as a cognitive skill, as a cognitive task. Anyway, there's all kinds of examples like this. In Israel, do you have direct-to-consumer advertising on TV for medications? So in the United States, we have advertisements on TV all the time for medication. So patients come in and they say, oh, I want this medication. I saw an advertisement for this medication, an advertisement for this medication. You don't have that here.
Now they're saying you can. No, they're saying that they don't call they don't call the medication by its name, but they said there's medication for this topic. Ask your doctor.
I see. Well, there's a right. Do you have in Israel the opportunity to send away a swab for a genetic test through the mail? Yeah, you could do that. So in the United States, this is happening now, and it's very complicated. People have no idea even the concept of what is genetic, let alone that now you have a 30% increase in your chance for diabetes or something like that. It's completely. It makes things are really complicated and getting more complicated. So let me step back and say, what are some of the at a high level, what are the domains of health literacy? There's some basic skills: reading, writing, how to use a form. I refer to the concept of document literacy. That means you have a form, you put your name here, you put your social security number there, how to fill out a form. That's called document literacy. Quantitative literacy is how you use numbers, numeracy, right? And then there's a whole arena of self-care tasks, depending on what the person's issues are. There's another area that we may not get to talk much about, really, which is navigation. How you get to do things, I give you a petek that says, make an appointment. Okay, so where are you supposed to go? What are you supposed to do? You have to know how to go and get this appointment and where to go. For example, to get to the main building here in Haifa University, you have to realize, you have to learn a lot, right? Okay, whatever, so you get it. Navigation. Interactional literacy. That's communication, interactions between people, talking to each other. And there's a fair amount of research in this area too, but it needs to grow. Okay, let me shift gears and talk about prevalence in the US. And Diane's going to be talking about this concept in Israel later on today. Okay. When someone asks you about prevalence, you should say, what's the definition? How are you calculating this? What's the definition? If I say, what % of people have low literacy, you should say, how are you defining this? Okay? So I'm going to tell you, this is going to be defined from the National Assessment of Adult Literacy. This was a about 20,000 household survey. So it's a big national survey, but 20,000 households, nationally representative American survey. This was done last in 2003. They were supposed to do it again around 2013. It's been delayed. This is a survey done by the U.S. Department of Education through the Department of Education Statistics, blah, blah, blah. It's a big project, and they measure literacy. And the way they do it, they create 4 levels: below basic, basic, intermediate, and proficient. And I'm going to show you some numbers. Basically, let me say, if you're below basic, it's very challenging to get information out of any health materials that are currently out there. Very challenging to do basic tasks. People who are below basic, if you give them a bottle of medicine and the bottle says, take 2 pills 3 times a day, they are unlikely to be able to take 6 pills out of that bottle. Okay? If you just give them that bottle and it says on the bottle, take 2 pills 3 times a day, the task of interpreting the information and then doing the task, you say, how many pills do you need for today? And below basic, they are unlikely to get that correct. Okay, so think in your mind, what % of American adults are below basic? Okay, just think in your mind, what is below basic in the United States? Okay, so this is the information from 2003. It's probably very similar now, even though it's 10 years later. And so you can see that you have, about 14% of American adults have below basic literacy in English. Most of those people, their only language is English. Okay, so it's not like you could do this test in another language and then, okay? On the next slide, I'm going to, I'm going to show you the same thing by race and ethnicity. Okay, so you saw it was like 14% on average in below basic, right, and 22% basic. On the next slide, I'm going to show you by race and ethnicity. So I want you to think, what will this number be for African American, for Hispanic, and for white? What will the number be? Anyone want to guess? It's hard to guess like this. It's hard to guess. Okay? This is one of those situations where you do not need a very complicated statistical model to tell you that there's a big story. You don't need a t-test, you don't need any kind of p-value. That's a big deal, right? That's very, very different by race and ethnicity. So what's the story? What's going on here? Here is the same information by income. Direct line by income, right? Here's the same story by education level. Now let me take a pause. And I want to do a little survey, because actually, another message I want to communicate is people who have education really need to see that as a kind of a gift. In my mind, it's a kind of a privilege. A lot of people don't have access to education. Okay, so I went to college. I went to graduate school. My wife went to college. All my brothers and sisters went to college. Anybody else like that here? All your brothers and sisters went to college, right? Okay, not everybody here. My parents went to college, and my wife's parents went to college. Anybody else? Okay. My grandfather and my wife's grandfather went to college. Anybody else? My grandmother and my other grandmother, my wife's grandmother and her other grandmother, all of them went to college. My Oma went to college in Dusseldorf. My other Oma went to college in the United States. My wife's Oma went to college in Heidelberg. Her other grandmother went to college at Radcliffe at Harvard. This is tremendous educational privilege. Multiple generation, including the women. And if you could say anything about international public health, I think that it's education. you could say anything you want, but if we can get access to education for women, we will succeed. I think we will succeed. Anyway, the question about education is, what are you going to do with it? How will you improve the world with your educational privilege? That's how I feel about it. Because if you look at this picture, if you don't finish high school, it's very hard for you as an adult, to have literacy. Tzvi Davis, I put his picture up. He only went to 9th grade because of the war. Okay? And I think there were a lot of people in that generation that their education was disrupted because of the war. We have refugee populations all the time. It's very hard to think, how is this going to affect the education of their grandchildren? But in fact, it will affect it, because if you disrupt the education, it will have multiple generations of effect. Okay, this is my little soapbox. Okay, everyone's supposed to laugh at this. Okay, even the dyslexics are supposed to laugh at this. That's like a mistake, right? You don't sell school that way. Okay. Here's an example of another data. This is data from something called the NAEP. This is another American big survey. This has to do with people who have succeeded to stay in high school until 12th grade. Okay? So this is from 2005, the last time they had the data available. They're currently processing the new data because they did it in 2013. And this shows you the same categories, below basic, at basic, proficient, and advanced, for people by race and ethnicity, for people who made it to 12th grade. So they actually are succeeding educationally. And you can see there are a lot of people not performing well. This means there are phenomena like social promotion. And, you know, I don't know so much about the Israeli primary education system, but everything I hear has been very, very bad. Very bad. And average class size, 36, 38, with one teacher in the room. That's going to have effects on the future of Israel. That will have effects. Even in Georgia, which is we consider a poor state, the average class size is 30. And it's one of the poor states in the United States. Mississippi, poor, also the same. It's, you know, איזשהו בושה לדעתי that you have 36, 38 students in a classroom. You only split the room if you get to 41 students in a class in Israel. You know this, right? This is very strange to me. It's really very embarrassing. Okay. On the next slide, I'm going to show you, this will have a huge effect on the future. Who's going to be working in high tech if, in fact, you have 38 students in a class in the next generation? Okay. In the next slide, I'm going to show you the same thing for math. For math. So I want you to think, what are these numbers? You see 21 for white, 46 for black, and 40 for Hispanic at basic in reading. What do you think it will be for mathematics? Better or worse? Better to say worse. Ready? Oh, that's a mistake. Okay, not everybody can read that, right? If you're gonna get a tattoo that's disgusting already, at least spell it correctly. Okay. Mathematics. This is very, very bad. This is very scary, right? Because in a lot of communication, basic math concepts are just assumed. Are assumed. When you go to the doctor and you say, because of this test, I think you have a 30% chance of developing breast cancer, or whatever. Assumed. What does that even mean to anybody? People don't know what that means. What they hear is your affective communication. If I say to you, your cholesterol is 206. So what you learn, you don't know what that number means. You only see that I'm feeling okay. It doesn't sound so bad. But if I say, no, let's sit down. Listen, your cholesterol is 206. We have to talk. We have to talk about this. So now you know how I feel about it. But you don't know what this number means. Like the number doesn't mean anything. And in general, I think that's how patients are operating in health contexts. They don't know what these things mean, but they just are looking to see how you feel about it. And at least in this regard, I think that there's a lot of room for improvement for doctors in Israel. Okay, and in the United States too. Okay, that's a mistake, that's a mistake. Okay, so I'm going to skip this. Basically, in this slide, I did a project. I looked across a whole bunch of studies, and I came up with very, very similar things that we found before on the previous slide. So let me just go ahead. So why does this matter? Why does this matter? Let's try to focus on why all this information matters. It matters because if you look across a whole bunch of studies, these phenomenon, literacy phenomenon, are associated with a lot of bad things. Here are a lot of things, and there's many more. The slide got too busy, of all the things that health literacy has been connected to in terms of health outcomes. I want to just say that not everything is so perfect. Whenever you see a star, that means that the information is actually, there's multiple studies and they don't all agree. And I'm personally happy to have put several stars on there because I think it's very important when you're doing research to also be honest and to publish the negative studies. I know many, many people who have negative studies on their desk that they're not publishing. It's extra work. It's harder to get them into the big journals, but it must be done or else everybody else is running around trying to understand what's real and what's not real. Let me focus a little bit on mortality. If you like, that's kind of the final ultimate outcome, at least to everyone so far. They say there's this one guy, but I don't believe that. Okay, there's two studies I'll show you. The Aging Body Composition, ABC study. This is about 2,500 people, and they were about 75 years old when they started the project, and they followed them. And I'll just show you that over the course of about 5 years, the mortality rate was close to double for people with limited literacy to adequate literacy. Here's another study. This is the other big study. This is also maybe a little bigger, 3,200 people or so. And here, very well adjusted models, very well adjusted. The hazard ratio is about 1.5. So that means there's a 50% increased chance of death within the 80 months of observation. Just to give you an example, this is tantamount, this is a ki'ilu that you took a chronic disease like diabetes and added it to the population. A 50% increased mortality rate over the course of 8 months. So that's like a very big effect for mortality. You know, and this is after you control for everything. You control for smoking, blood pressure, everything. And you have this kind of hazard ratio. The 3 lines here, you can see like a stepwise function, low, middle, and adequate literacy. So how does it work? Why would it be that a person with low literacy ends up having health outcomes? What would be the connection even? How should it work? And I would say I'm going to show you some simplified ideas about how it would work. We don't have time to go through everything, but this is kind of so I've already showed you that some of the main predictors of health literacy are race and education and age. I didn't talk so much about age, but it's very important here too, primarily because access to education has been improving over time. But that's another conversation. There are other phenomena as well, but that's one of the main issues. In particular, by the way, for women, access to education has been improving dramatically for women. But I'm going to set that aside for now and stop that part of the conversation. I also want to set aside a bunch of other things, things like neurocognitive and neurosensory phenomenon. If your problem is vision, we actually have another way of correcting that. It's glasses. Glasses, 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 glasses. Glasses, glasses. Most people, the majority of people in the United States whose vision is not good enough to be able to read, that could be corrected with glasses. Or cataract surgery. That's number 2. If you think of who's so blind that they cannot read, most of them is because they need glasses, refraction. something simple, already worked out a long time ago, or cataract surgery. And, but who are the people who don't get glasses? If you didn't have glasses, it would be impossible, right? Because you're a reader. You need to read. I need to read. If I didn't have access to what I could read, I would forget everything, and it'd be impossible. But if you spent 30 years of your life, 40 years of your life kind of struggling to read, it's like, you know, so there is an overlap between the people who don't get the glasses and the people who are non-readers. But let me set it aside because it's a different intervention. If the intervention you need is to need support for memory, that's a different conversation. Also, let me set aside as a different conversation issues of language. If really what you need is to provide health services in another language, that's another intervention. That's a different problem. That's saying we have to have health systems that can provide language-appropriate services. And really, it's a very big issue. But let me just, for now, set it aside, because the intervention is clear. You need a language-appropriate health services. You need public health messaging in the appropriate languages. But by the way, just because you provide it in another language doesn't mean that it's going to be simple enough for people to understand. It could still be too complicated in that language. When, you know, just because you put it into another language, it may still be too hard. So you still have to have a literacy construct in your mind when you provide language in another, you know, language-appropriate services. In the United States, the second most important language is Spanish, but it's hard to even say here. It depends on exactly which town you're in here, because in one town it's Arabic, in another town it's Russian, in another town it's Amharic. You know, there's a lot of language complexity here. But we have in the U.S. some language complexity too. Other kinds of things, but let me put them aside. So what I want you to see on this slide is there's 3 boxes, and each one has a box on the left and a box on the right. The top box in the United States is a very, very big problem. It's access and utilization of care. In this area, Israel is much better because everyone has insurance here for the most part. You have refugees who don't have good insurance. But really, the population is has at least structural access. Structural access. In the United States, we have millions of people without access to care. You know, really, if the Affordable Care Act will work well, if the Obamacare will work well, in the next couple of years, we will add 30 million more insured people, which is, you know, which is a step in the right direction, but we will still have about 14, 15 million without. So it's not going to be complete. But at least in terms of how you can walk in the door, Israel is actually in a pretty good spot. But it doesn't mean that people know how to use the system, and that's kind of how people are interacting with the healthcare system. The next kind of box down here, so that's this up there. Oh, actually, before I go on, let me just talk about this a little more. Anything you say about patients and their skills, you should say something in parallel about the system. So with the patients, you know, how do they understand how to get, you know, for this I go to the pediatrician, for this I go to the emergency room. I'll give you an example just to make it kind of concrete. I said to a patient once, do you have email? She said, yes. I said, fine, this is my email. You know, if you have a question, you can email me. So she sent me an email about 3 months later. My husband is unconscious on the floor of the bathroom. So I was on the computer right then. So I sent her an email back. I said, call 911, you know, call for emergency, you know. And she wrote back, I can't. So I called her on the phone. I said, call 911. She said, I can't. I said, what are you talking about? She said, my son is wanted by the police. If they come, they'll arrest him. So I said, tell your son to take a walk. I'm calling 911. You know, so you have to kind of have a certain understanding of how to use the system. And some things you go to the emergency room for, some things you go call the primary care doctor for. And so, you know, you have to have some seichel, right? But you also have to interact with the society to understand how to use your system. As it turns out, the funny thing, we all laughed, the fastest way for her to communicate with me that day was by email. I was sitting right there. It actually worked. We laughed, but it worked. If she tried to call my office, it would have taken her a long time. She would have left a message, someone would call. Leaving a message is irrelevant if you have to call 911. It actually worked for her. Musa. Okay, so there are ways that the system can be made much easier. And in general, it has to be. We have to think about it from the patient's perspective. Very commonly, health systems are developed for the convenience of the people who work there. And it's very important to take the patient's perspective of how to use this. How will they actually be able to interact with it? For example, we have people have made tremendous amount of development in personal health records. Almost none of them are actually used because they're too complicated and the patients are not able to use them. Anyway, let me go on. That's kind of how access and utilization of care. There's a lot to say about this, but I want to move on. The next part of it, at least for me, is when you actually are interacting with people. And by the way, access and utilization of care, it has to be also in the public health sector has to be very involved with that. Anyway, in the patient, in the interaction when you're sitting with someone, and this is any provider. I'm a physician, so I think about that, but really any provider, and in any context, there are going to be things about the patient and things about the provider. The patient has their own knowledge and beliefs and attitudes and opinions and their own sense of self-efficacy, their own sense of empowerment. But all of those things can be said about the provider too. They also have their own sense of self-efficacy, their own communication skills, their own knowledge, beliefs, and attitudes. Anybody who says something about a patient, please ask them, how about the professionals? They have the same issues. Too much we focus on the patients, we have to focus on the providers as well and find a way to develop both of them. And then, of course, there's the vast majority of all health, which is outside the health system. The vast majority of health is just people living in their lives, in their homes, with their mother, with their kids. And that's what we call self-care. And there are patient factors there, and then there are extrinsic factors there that will have a big impact on how people do. Now, in general, when you think about these problems, the purpose of making a model like this is to say, like, why do we go through this? The purpose is to say, what are we going to do about it? How are we going to do an intervention that will actually possibly influence any of the processes that actually develop the issue? If you want to make an intervention successful, you have to understand what the pathways are so that you can have an intervention that works. But it really depends on the context. You know, there are situations where the health outcomes really are influencing the literacy. You know, if you have a disease that starts early and disrupts your primary education, then you're not going to solve that by a literacy intervention. The disease came first. So you have to figure out where to put these kinds of interventions. I'm going to give you some examples of parts of our health system that complicate the whole conversation. Okay, here's one. Someone read that out loud.
Someday you'll act like you understand.
Yeah. So the thing is, she says it much more angry than that.
Sorry.
Yeah, that's okay. It's okay. So we have a general system. We have a general phenomenon that that has a lot of hierarchy and a lot of shame. Why is it that when a person goes to a doctor that they don't feel comfortable asking questions, or that they don't feel that they can admit that they don't understand what's going on? Basically, we have created a culture where, you know, as if the doctor's time is more important, or, you know, that it's embarrassing to say that you don't understand something. That means that we have a lot of barriers. In fact, it's very hard for many, many people to have the social capital and the empowerment to go in and say, I don't understand what's going on, you know, or you know, you gave me this medicine, but I didn't like it. I didn't take it. Give me something else. What usually happens is the doctor says, take this, and the patient says, okay, and then they don't, but they never talk about it. Never talk about it. Why? It's partially because of shame, it's partially because of hierarchy, And that has to change. In order to get to a shared decision-making possibility, we have to empower patients, and we also have to empower doctors to allow themselves to be disempowered, to allow themselves to be comfortable with the fact that they're not the boss. They're actually, it's a service economy. The doctors are actually serving the patients, but they don't know it. Yeah, when I was very young, I told the class yesterday that my parents told me that I could do anything I wanted when I grew up, right? My parents said, you can do anything you want. You could be a cardiologist, you could be a pulmonologist, you can be anything you want, anything you want. That was because they had in their mind that I was going to be a doctor. That's done. That's done. That is over. That's done. That is not the concept. Healthcare is not that way anymore. The purpose of being a doctor is to be in service. The purpose is actually part of the service economy. You are there to help empower this patient, not to put them down, not to control them, but to bring them up. What? But city at school? Yeah, I had no choice. But it's very fun. It's fun to be a doctor. Okay. So who knows where this is? LA. It's LA, right? How many lanes do you have? Even Kvish, you know? Right? This is like 1, 2. Okay, what's the idea here? The idea here is I'm talking about health literacy now, right? But in fact, commonly, this particular phenomenon travels with a lot of other phenomena. You know, what recommends a lot of the research that I showed you is that they were done with very nice statistical methods to control for other phenomena, to control for income, to control for race, to control for this, to control for that, control for this, control for that. In fact, a human being is not a statistical model. A human being is not a regression model, right? If you want to go back into the world and to do an intervention, you're going to have to do that with people, not with statistical models. And in fact, if you have one vulnerability and it travels with other vulnerabilities, you have to think about how this will influence your whole project. And your project may be starting with literacy, but it may have to bring together other issues, other perspectives, things about access to care. In the US, that's income, right? Things about social support, addiction, mental health, so many things. Okay, what's this? Where's that? Anyone know where that is? Well, it's in Scotland, but yes. Okay, so what does this mean? This means that in fact we are very, very influenced by our life course, where we were born, what kind of family, what kind of education our grandparents had. If you look at the vocabulary a person has when they go into kindergarten, that is incredibly predictive of their whole life course. Now, there are people who can get off the path, and we all know people who have been brilliant and have gotten off the path. But most people really stay in the path that was created for them by the world, okay? Why, so it's just very hard to underestimate this phenomenon. And it's really humbling being in a room with people from a lot of different countries. It's really humbling, because we have a lot of influences on us for where we were born and what our circumstances are. And from an education perspective, if you don't start early, it's very, very hard to change and get off that path. It can be done, it's just most people don't. Okay. This is just to stop for a moment and see if people have questions to this point. Oh, see, I got it right. Okay. I know you're very embarrassed to ask questions. That's what they say. That's what they say about Israelis. Lo kol kach. All right. In public health, the messages are very complicated a lot of the times. We say, today this vitamin is good, and then tomorrow we say, oh, no, forget about it. That vitamin wasn't good. Actually, it causes cancer. We have to compete. Our messages have to compete with other very successful campaigns. I mean, if you look on TV, our messages have to compete with sex, with drugs, with rock and roll. It's very hard. You know, we have to be sexier than sex, right? We have to say that stopping smoking is even better than drugs. I mean, it's like, but it's very hard. By the way, there's much more smoking in Israel than in the United States. I don't know if you know this, but it's really another busha. Really a busha.
Depends what state the states.
No, everywhere now. It,
Some of the states are,
which one?
On subpopulations, not everywhere.
If you go by the state level, every state in the United States is lower than the average in Israel. For the average in the whole country. Every state in the United States is lower than the whole country. Of course, it depends. I was just sitting here in Ramat HaKarmel, and you know, the worst is you see a little dog shit every once in a while. I'm serious. There's some wonderful. I visited in Modi'in. There's like no one is smoking there because they're all Anglos, but okay. I'm telling you, there's more smoking here than there is in the United States. If you come and visit us, you'll see. We kick them out of the buildings. We kick them out of the cities. It's really different. You don't believe us, but you don't believe me. But I'm telling you, there's more smoking here. It's a problem. Someone told me they were working on smoking interventions. Yeah, you're doing that too. Maybe. Yeah. Anyway. Okay. Let me just move on. I need another person to read for me. And this one I want you to read very loudly. You're sitting in the middle by yourself. You're going to read this one out loud. Okay? This next one. Gizman. Okay?
It's too complex.
It's too complex. Read it.
Nation needs AIDS. Free men and women. Let's protect ourselves.
Okay.
I can't read the rest because
Yeah, it's too small. Too small. That's right. Exactly. Does anybody else want to read it any way differently? Anyone want to read it differently? What does this even mean? What does that mean to you?
that little hyphen.
Yeah, there you go. Okay, so you noticed this. But as it turns out, if you're driving on the highway and you see this sign, what are you going to say? You're going to read it like you read it. The nation needs AIDS. But, you know, this is a big mistake. You know, right? You're supposed to read, the nation needs AIDS-free men and women. There's the little hyphen, this little hyphen here. So that someone made a carriage return right there and makes a huge billboard. That's obviously a disaster. Okay. So I think I showed you that health literacy can lead to bad health outcomes. I showed you some of that. There's a lot more to say about that. I think I showed you that there's significant racial and ethnic disparities in literacy. I didn't really show you in health literacy, but I could show you that too. But the question is, how might differences in health literacy lead to racial and ethnic disparities? Maybe it feels obvious to you, but I'm going to give you a few examples. Here's an example from a project of mine. 200 or so patients with HIV. And the question, we looked at a lot of different things, but we saw that the medication adherence rate was lower amongst the African Americans. The African American patients had worse adherence to medication. And if you did a kind of statistical analysis, the odds ratio, but you didn't include literacy, the odds ratio was 2.4 times more likely to be non-adherent in the African American group versus the white group. But if you included literacy, the effective race went away, and the only significant factor was health literacy. So in fact, health literacy, people with low health literacy were much more likely to be non-adherent with an odds ratio of 2.12, and the effective race was gone. That means if you want to design an intervention, if you want to do something about this problem, and you don't look at health literacy, you're going to go in the wrong direction. You're going to do an intervention that has thinking about the wrong thing. Okay, let me give you another example. This is from End-of-Life Decision-Making Project. There's a series of projects that say African Americans want more aggressive care at the end of life. More ICU, more everything. And I was always concerned about how they did those projects. So what we did was we created an educational video. It was a 2-minute long video, really short video. And in the unadjusted analysis, African Americans 4.8 times more likely to choose aggressive care at the end of life. Unadjusted analysis for people who did not get the video. Okay, so we had a randomized study, control arm, no video, intervention arm got the video. And if you adjust for health literacy, the effective race went away, right? If you look at health literacy in the verbal arm, unadjusted, huge odds ratios. You never see an odds ratio of 17. It's a crazy number, odds ratio of 17. And when you adjust for everything, it's still quite significant. Health literacy is much more likely to be associated with the outcome of wanting more aggressive care. In the video arm, no difference by health literacy, no difference by race. That means they needed an educational intervention. They needed educational support. And if you gave them educational support, there was no difference by race or ethnicity or literacy.
And education.
Right, no difference by education. Yeah, no difference. With the video. It was a short, simple video that we developed. It took a lot to develop it because we wanted to make it very simple. And we had a whole series of projects to make this video. By the way, we've now made 18 of these videos in end-of-life context, and it's going very successfully. I'll give you a link, a website to go to if you're interested. Okay. One of the things this means to me is that if you want to do work on health disparities, you also have to measure in those projects, you also have to measure literacy, because this is another pathway that disparities might be happening through. And if you measure literacy and then you see that that's another important pathway, this can influence how you're going to design the intervention. Of course, you know, the impact of primary education, but it's hard to even talk about that very fast. I think it's very, very important, and I have other projects that have been looking at this, to improve the activation of the patients and the providers and how they communicate. Maybe we'll get to talk about that more. There's no question to me that simplifying helps everybody, and we've done some work in this. Simplifying will also help the educated people. If you look at knowledge acquisition and retention, it also goes up when you simplify. It also goes up for educated people. You know, if you ask, how much did you learn and how much do you retain 2 weeks, a month later, it will help also the educated people. If you have a long list and you say you shorten that down to 3 things, that's going to help everybody, not just the people with limited education. Also standardization. There's a lot of examples in the United States that I know about. I don't know so much in the Israel context, but you know, if you go to this pharmacy, it's written this way, and you go to this pharmacy, it's written this way. Everything is different one place to another, and there's a lot of opportunities for standardization. And then, just very briefly, I'm going to show you some slides about opportunities from health information technologies. And in general, when you think about HIT, you should think about 2 things in the health literacy context. One is, what is going to be the interface that people can use? Because the general internet is too complicated, you know, and I've shown this in different projects. And the other thing is, how are people going to access it? How are people going to access? How are they going to actually use it? Do they have a smartphone? Do they have access? You know, in the United States, many people do not have a home computer. Poor people do not have their own computers. Sometimes they're now having a cell phone with a smartphone before they have a home computer. And so you have to jump ahead technology. I'm going to skip this for sake of time. I'm going to skip a bunch of slides that people are interested. We can talk later. I'm going to skip all this nice stuff just to show you some of the projects and that are working for us. I'm going to skip all this. I'm going to skip this too. There was a mention before about care transitions. We had a very, very successful project to improve education from when you're discharged from the hospital to go home, decreasing the readmission rate by 1/3 in a public hospital, and now it's being done around 450 hospitals have had trainings in this project, so it's going to develop. By the way, we have like 5,000 hospitals in the United States, so there's a big system, right, or many systems. So 450 is not even so much, although it's a lot for me, it's a lot of work. This is just to show you that you can make information, you can make tools that you can then use to teach patients. You can't just make a brochure and expect anyone will learn anything. You will find it on the floor when you take them to the nursing home behind the door with all the dust. You have to empower patients. You take the information and you use it as a teaching tool with them. So, for example, the appointments go to a schedule on, on a calendar. And even this, you have to say, let's walk through and look at your appointments. They won't do it on their own. Patients are just too passive. We train them for passivity. This is to empower patients about their problems, to talk to the doctors. Anyway, let me go on to show you something a little more cool. Okay, yeah. It's just to show you some cool things we're doing. We've developed a computer system, an avatar. The character talks to the patient, and the patient responds back on a touch screen. So the character can can talk about appointments, about medication, about a lot of things. And we've used this in a bunch of different contexts. This is from a project at Care Transition, being discharged from the hospital. And the character also has the information, and the patient has a copy of them for themselves. And these are things that people say. For example, someone said, "I prefer Louise." We called in this project, the character was called Louise. "She's better than a doctor. She explains more, and doctors are always in a hurry." Or, "It was just like a nurse, actually better, because sometimes a nurse just gives you the paper and says, 'Here you go,' and Louise explains everything." We could see that patients asked more questions to this computer system than they ask from the human. The computer will test them. The doctors will never test them. The doctors say, "Here you go." We try to train the doctors to evaluate comprehension. We try to train the doctors to say, "It's my job to make sure you know what to do when you go home. Tell me, how do you use this medication?" Because if you don't check, you don't know what people understand. It's called confirming comprehension, teach to goal. Many people are not doing it, but we can get the computer to do it. This is a new system. This character has an education module in CHF, in diabetes, no, not yet diabetes, CHF, pneumonia, and asthma, and we're developing more. And patients seem to really like her. One of the things that's very interesting is that everybody imagines that she's like them. So white people say she's white, Hispanics say she's Hispanic, Asians say she's Asian, blacks say she's black. You can't really quite tell. So everybody likes her. Everybody likes her.
She's a man.
Yeah, this is another system that we have. This character, Tanya, we've used her in a few projects. The one that we're currently publishing an article from is to promote walking in the elderly. In particular, Tanya, the way it worked, maybe I have a slide for this. Here, I have a slide for this to show you. The way this project worked is we had randomization at the baseline. We then had a study visit at 2 months, so 2-month outcomes. And then we had study visit at 12 months, okay? And the way it worked, everybody got a pedometer. And then in the intervention group, they got the pedometer, and then they also got Tanya for 2 months. Tanya only for 2 months. And in general, in behavior change interventions, really the issue is maintenance. That's the holy grail. So what I can tell you is, in this project, Tanya had a very nice impact on walking, but only during the 2 months. By 12 months, the intervention effect went down. We did not have a robust enough maintenance phase intervention. We didn't really have enough support for the behavior change. And this I'm going to skip. It basically says what I just told you, but I'll give you an example. People said, "Terrific, damn friendly, Tanya, beautiful attitude. She spoke plainly, her voice wasn't rushed. I told my wife I have a new girlfriend." 83-year-old guy. It's terrific, she's human, she's intelligent, she's very reliable, doesn't say anything foolish, she had a wonderful manner. But it's not for everybody. Some people said the opposite. I didn't really like her. In the Tanya project, randomly, within the intervention group, we took, within the intervention group, randomly, half of them got a more emotional Tanya. She spoke more kindly, more empathically. She would say, every day she would say, "It's nice to see you." The way it worked was that they connected their pedometer with the USB cable to the computer, so the computer knows how much you're walking. tries to set a goal with you, tries to say, oh, you didn't quite meet your goal, let's talk. And so randomly, you get a high empathy character or a kind of a normal character. By accident, we got a woman and a man who were living together, and they both were in the intervention group. And the man got the high expressed emotion, and the woman got the regular Tanya. And she brought it in, and she says, I don't know what happened to her, but she likes my husband much more than me. What did I do wrong? But my husband really likes her. So whatever, you have to, you have to be careful. Okay, let me make some conclusions. Here are some websites that you can go if you're interested. We really only had a kind of a short time. The care transition research that I've been doing, a lot of it is on the website there. It's called RED, Re-Engineered Discharge. Actually, that project has gone very well, and the university has now made a commercial license to a company to promote this idea. And I can say as a statement of conflict of interest, I advise to this company. So you can also go to that other website, Engineered Care, if you're interested. The videos for advanced care planning, we have now made a foundation, and it's going very, very well. It's a nonprofit foundation where we have programs in 50 hospitals right now, and it's going to expand rapidly. We have a new project with Blue Cross Blue Shield of Hawaii to bring it to 80 facilities next year in Hawaii. And I'm telling you, that will be awesome. That means I have to go to Hawaii 4 times next year. It's a long flight, but someone has to do it. And it's you can't just think of these things as you're going to put a video here. It's really how to change the whole system, a cultural change in an organization. Because actually, nothing will happen if you just give someone a new tool. Any new tool for health purposes, it has to be integrated into the workflow. It has to be synergistic with the people who work there. It has to be part of their own, they have to take it on as part of an organizational cultural change. You have to bring it into the quality improvement model for that system. And so really the effort will be training and integrating this agenda into the whole system. And this is going to be, a statewide effort. We're currently negotiating for a whole nother state effort for the whole state of Oregon. And so there's a lot of possibility. Now, one last pitch is that I help run a conference on health literacy. It'll be in DC at the National Academy of Sciences in October. I'm hoping that there will be an Israeli delegation. There was last year. And that was very nice to have an Israeli delegation to the Health Literacy Conference. And it's really been an honor to help run this conference. It's really been a zchut rabbah to help coordinate that. But it's richer and richer as we bring people in, and it's been very nice to see that this is beginning to happen in Israel. And so Diane was there, and later on today you'll hear some of what's come with her work here and others here in Israel. So I hope that you will give them a warm welcome and also support them to continue to develop that work in the future. So thank you.